failed AGV. Because nowadays everyone is telling that is giving a more control.
Correct, ma'am. So this study, there was a bias there. I was doing only AGVs when this study was happening. Now that the ACV has come, I've started doing those. I did not have any experience with the RT implant.
All the were pretty superior nasal quadrant, and
no, we start off with the superior temporal, superior nasal, and then inferior.
No, was the first? Okay, you fast is?
Yes, and 4 out of the 6 eyes were not my first AGVs. It was done elsewhere. Then they came to me. I had put the second AGV.
Second AGV you put in?
If superior nasal is my first choice, if superior temporal is already taken, or if there is a trab also, and superior nasal or superior temporal AGV first, then I go for an inferior. Inferior was only in one eye.
And inferior one you didn't, in all cases you do a patch graft?
Yeah, I use patch grafts in all my cases.
So just a word of caution, look, when we have to do a second implant, we do a second. When we have to do a third, we have to do a third. There is no option in certain patients. At the same time, having the complication that we have in 1 out of 6, so then we have to interpret the results from our study.
Actually, the complication, the tube exposure is definitely a complication, but the endothelial decompensation was part of the eye syndrome also. So because there's an endothelium problem in that syndrome, that also leads to the tubes were quite far away. The second tube was in the sulcus. The first tube also was quite far away and very small in size in the anterior chamber. So it did not show me that this is the cause of, it could contribute to some extent, but the disease itself had that component of endothelium decompensation. But yes, tube exposure is definitely a big complication.
Thank you.
Thank you.
Can we now have Dr. Vaishali Jadhav? We'll be talking about ab internal Schlem's canal viscodilation and trabeculotomy by Omni system.
A very good morning to all of you. The Omni system was developed to manage resistance at 3 different sites: the trabecular meshwork, the Schlem's canal, and the distal collector channels. The Omni system is an MIGS device that can perform ab interno circumferential canaloplasty and trabeculotomy with a single handheld system. We have a video running on the kiosks if you're interested. We are now presenting retrospective analysis of the first 30 eyes that underwent this procedure with a single surgeon between August to December 2022 at our center. A target intraocular pressure was set for each eye preoperatively. No blood thinning agents were discontinued. The postoperative follow-up visits were at 1 day, 1 week, 1 month, and then every 3 months thereafter. All anti-glaucoma medications were stopped after the surgery, and they were then reintroduced one by one if at any point of time the intraocular pressure was not satisfactory for the stage of the glaucoma. The case notes were compared for pre and post-op vision, pre and post-op intraocular pressure, and pre and post-operative number of medications at each visit. Any complications were also noted at each visit. Now, of these 30 eyes, 11 eyes underwent standalone canaloplasty and trabeculotomy, and we'll just call it standalone Omni, while 19 eyes underwent canaloplasty with trabeculotomy combined with cataract surgery, and we'll call them phaco Omni for simplicity's sake. For the purpose of the review, complete success was defined as any eye that achieved intraocular pressure without any supplemental intraocular IOP-lowering medications. Qualified success was defined as any eye that did the same but with medications. Failure was defined as any eye in which IOP could not be controlled with IOP-lowering agents and needed another surgical intervention. This is our demographic data. Most of the age was similar in both the groups. Most of the patients were in their 7th decade of life. We had more males than females. The group A had more worse glaucoma. It also had more pre-op medications than group B, and the pre-glaucoma surgeries before the Omni was done was also higher in the group A as compared to group B. Primary open angle glaucoma was the commonest type of glaucoma, followed by secondary open angles and ocular hypertensions. We also had a few normal tension glaucomas and 2 narrow angle glaucomas post-PI. The mean baseline intraocular pressure for group A was 22 millimeters of mercury, which reduced to 13.37 millimeters of mercury at 12 months. The mean baseline pressure for group B was 18.31 millimeters of mercury, which reduced to about 13 millimeters at the end of 12 months. We had a significant reduction in the number of medications in group A, which went from 3.5 to 1.2 at 12 months. Similarly, for group B, the medications went from 2.8 to 0.5. So 1 out of 19 eyes was on medication at 12 months in group B. Most of the patients had intraoperatively some amount of bleeding on the table. However, only 3 eyes of the Omni group and 10 eyes from the combined group had blood clots in AC on day 1. 7 eyes had layered hypema less than 2 millimeters, but it resolved on its own without any sequelae. IOP spike more than 10 millimeters of mercury from baseline was seen in 2 eyes, again managed medically. None of the eyes lost vision. So significantly, we'll just go to compare our results with the published studies. We have the Gemini study, which compares the canaloplasty and trabeculotomy and cataract surgery and gives 12-month outcomes. And another prospective study from clinical ophthalmology, it gave 12-month outcomes for combined GAT with ABIC in conjunction with phacoemulsification, which is not the same as what the Omni does, but sort of similar, and they had the same number of eyes. So the intraocular mean pre-op intraocular pressure was similar in all the 3 studies. The 23.9 is the unmedicated wash-off from the Gemini study, but the medicated pressure was 17, so it's the same. Most importantly, for patients who had more than 20% of reduction, our numbers are slightly less, quite less than compared to the Gemini study or the Habash et al. Study. But it could be because we also had normal tension glaucomas and a spectrum, but none of them had any medications. Significantly, intraocular pressure less than 18 millimeters at 12 months, our patients were higher than Gemini. Limitations are, of course, retrospective analysis, loss of data at 12 months. But however, it does suggest that combining canaloplasty and trabeculotomy with cataract surgery might be an attractive option in mild to moderate glaucomas. One could also offer it in advanced glaucomas because it takes less time and it has a better safety profile than other traditional surgeries. But obviously, the numbers are very small and you need larger cohorts to sort of validate our outcomes. That's our clinic there. Thank you.
Nice presentation and nice study, of course. I just wanted to know, this is just 12 months study.
Yes.
So it tends to, it's well documented, it tends to the wean off the effect of vasodilation after 12 months.
Yeah.
So it should
Yeah,
be a
we are
longer.
carrying on, but this is just the early results of the thing, so we continue to monitor
Because
them.
12
yeah.
months is well documented, it
Yeah,
works.
yeah.
And after 12 months, it's the effects wean off.
Yeah.
Thank you.
Nice study. I have wonderful results. What do you mean by narrow angle glaucoma?
Well, those are the patients who probably had, these 2 patients had narrow angles. They underwent iridotomy and then they had cataract. So post-iridotomy, the pressures were, the angle was at least open for 270 degrees. And then they had significant cataract with it. So
they are
That's-
PACG patients.
they are PACG, yes. Yeah.
But these patients have angles which are open for
After
270
PI, but
After
at least
PI?
270 degrees, at least. Yeah. If anything less than that, then no.
And
Not
in
for
these
the-
patients, the surgeries were combined.
Yes, the cataract was removed and then they did that thing. So there were just 2 patients in there. So we don't really see a lot of angle closure in the UK. So
Right, so cataract surgery itself is likely to have an
Yes.
impact. Mixing these 2 groups
Yeah.
for any further publications and presentations, the results probably will be better if you present those separately.
yes, that's what we thought, because that's why the data wasn't said about the standalone Omni, because that was just offered to patients who couldn't come, patients in their 90s who can't come, or just wanted to reduce their medication load. So yeah, it's a little hodgepodge there, but I think going forward it will only be with the cataract.
I think my suggestion will be you have to carry on the study for the next conference. We'll again see in the next
Yeah, the
presentations.
data's
After 1
collection
year
is
again.
going on, it's ongoing, so yeah, we'll
It
analyze.
should be ongoing.
Okay.
Nice, thank you.
Distance at 500 and 750 microns, trabecular iris space area at 500 and 750 microns, the lens vault, anterior chamber depth, angle to angle distance, the ciliary body thickness were also measured. The measurements of actually 3 consecutive readings were taken, basically the nasal and the temporal angles, and the average of 3 readings were taken. Analysis was done using Mann-Whitney test, and a p-value of less than 0.05 was considered significant. So coming to the baseline parameters, we had a slightly older age group in the diabetic group. Males were more than females, but maximum of the patients in our study population had diabetes between 5 to 10 years, and most of them had mild or no retinopathy. Then again, when we correlated the gonioscopic findings with the duration and severity of diabetes, the correlation coefficient was negative. That means as the severity and the duration of diabetes increased, the angles tend to close up. And then these are the UBM parameters. Except the trabecular iris space area in 500 microns, all other parameters, the median and the interquartile range values, we found that the p-value was significant between both the groups. Similarly, except the central corneal thickness, all other parameters like the lens wall thickness, the anterior chamber depth, the ciliary body thickness was all. The difference between the non-diabetic and diabetic groups, the values were statistically significant. So we can assume that the changes in eye due to the pathophysiology of diabetes, which involves the microvascular changes and neurodegeneration, is related to the severity and the duration both in diabetic patients. Now, studies have shown that long-term effects of diabetes may affect the lens thickness as well as the other angle parameters, causing narrow angles, which corroborates with our study. This difference in diabetic retinopathy patients may be due to enhanced oxidative stress and or the reduction of antioxidant status, which may lead to the thickening of the anterior posterior lens diameter and a reduction in the anterior chamber volume and narrowing of the angle. So here, except the central corneal thickness, all other angle parameters were found to have statistically significant difference in the values. These are some of the studies where the ultrasound biomicroscopy has been used. A study by Kaushik et al. Has shown that gonioscopy and ultrasound biomicroscopy can be comparable, though gonioscopy is a cheaper alternative in our setup. Then the study by Garuradri et al. Has shown that the anterior chamber angle between normal subjects and angle closure patients can be compared and found longer trabecular processes in the diabetic patients. Similarly, lens thickness was found to be increasing with the duration of diabetes by Lockstrop et al. Then there are studies who have found significant association between diabetes and glaucoma, and the anterior chamber width has narrowed down with an increase in diabetes. And so the take-home message from here is the significant differences that we see between the diabetic and non-diabetics. While comparing the angle parameters, we can say that there is a correlation between the increasing duration of diabetes and the narrowing of angles. And obviously, subjects with a greater duration of diabetes are more prone to have narrow angles. So the precision of angle parameter measurements via UBM has been found to be reasonable, though the marking of scleral spur has to be done manually, which is a matter of concern maybe. But UBM combined with gonioscopy can help in screening and following up of patients with diabetes to assess the risk of angle closure. These are my references. Thank you.
What is your definition in this study for the mild and moderate diabetics?
So actually we did not take as mild and moderate. This was all on the basis of the retinopathy findings. Like mild, moderate, severe was done on basis of retinopathy findings. And the quantitative parameter, we only took the random blood glucose at the time of examination, not the HbA1c.
Now, is it diabetic and non-diabetic? There are two groups.
So in diabetics, we again divided it into mild, moderate, severe.
Understood.
On basis of the retinopathy findings.
So the retinopathy findings.
Quite a few questions actually. I'll just what device was used for the UBM?
So the Sonomate UBM device, it had the
Does it have calipers, or does it do the automated calculation?
Not the automated, so it is semi-automated. We have to fix the scleral spur, and then we have calipers where we can measure it.
So even with the Cirrus 6000, the success of delineating the scleral spur is less than 80%.
So that's
How successful were you able to?
So actually, when we started this study, we had a problem. So we used to take consecutive readings, and we tried to find out whether the readings were normal, like all 3 or 4 readings, whether they're within that normal range or not. And then
So in identification of scleral spur, how successful is UBM in that?
So it is difficult because that's what I said.
Can you give me a number of how many scans were rejected because the scleral spur was not identified?
So we did in 150 patients, but we had to
You
so
were able
maybe
to identify in all?
No,
is
sir,
what
we were
you're
not
saying.
able to identify in all. It was difficult. because we have to find out the inner point of the corneoscleral wall and then point out the scleral spur, and from
On
there
a
we have to
forum like
measure
this,
all
it
the
cannot
measurements.
say difficult or easy. Were you able to identify in 150 of them, yes or no? If
Yes,
not,
sir.
then how were the
No, sir,
parameters
all these
calculated?
150 which were included, we were able to identify. But there were a lot of more patients which we actually called, but we are not able to calculate. So those patients were not included.
And how can you say that the changes in the lens and angle parameters that you have said correlates with the duration of diabetes? How can you say that it's not because of the age?
Age or refractive
It's
error.
not because of the
Age.
age. Sir,
So the statistics has to be calculated, and you have to do a multivariable analysis to be able to say that it's because of diabetes and not age.
Because your title is not justifying actually. Title is your diabetic and non-diabetic, not the complications with the diabetic retinopathy you are finding out the patients. You are selecting the patient as diabetics and non-diabetics. Diabetics which are mild and moderate. So it's not related. The title is not showing that you are talking about the diabetic retinopathy. Initially, your mind thought is diabetic retinopathy. So it should be the selected with the diabetic and non-diabetic, and diabetic level of diabetes. What is the duration of the disease? Okay. Thank you.
Thank you. May now have the pleasure of inviting Dr. Malvika Krishnan for the last paper. Is she not here? Yes. I will just give another shout out to Dr. Arnav Panigrehi if he is there. Dr. Sareen Shah and Dr. Supriya. Dr. Malvika. I am marking you three as absent because you're not there despite 2 calls. So we have finished early. I think this is a good opportunity to invite comments from Dr. Mitra on the presentations and his suggestions.
It is very heartening to see that the younger people are coming, younger generations are coming with the new studies, new ideas, and new thought processes. But there are few comments like if there is any surgical procedure involved, so you have to give a 1 or 2 just minimum small video clips incorporate on it, and of course the slide, the ornamentation of the slide should be there. I mean, little bit of what they were presenting, little bit of ornamentation is required. Otherwise, this is a good session, and all the presenters are done. They justified their topics and they presented well. Thank you.
Great. Dr. Lalita, any comments from you? Dr. Shivam?
Yes. It was nice session and very nice presentations and very educative for all. And of course, many more areas can be, especially like the first study that was very nice for the hematocrit and how the blood parameters can do. And of course,
3 apps.
so yeah, study was also nice. And second implantation of AGV, AGV space, then what is the area and what all things we can do is good. And of course, sutureless phacotrabeculectomy, and it's very nice to see there are no very limited complications in that. So of course, it has to be either we can go and have a look.
Great. Thank you so much. I think the hall can get ready for the next session.
Thank you so much. It was very good.
Thank you, sir. Thank you.
We'll take one group photo.